So I'm starting the medical legal aspects of broadcasting live workshops. Almost 20 to 22 years back, I was witness to a live workshop conducted for bariatric surgery in my institution in Pune. A very top-notch bariatric surgeon flew down from Mumbai to operate on a very senior officer's doctor's wife. The surgery went off well. He was in a hurry to go back. He flew back. The next day, patient had some pain. This was handled. None of the other people who were the team were on the telephonic conversation. But by the time it was realized that the pain was because of a leak, things had gone bad. The patient eventually expired from septicemia almost 15 days later. So that is what, and many incidents like this have led to. In July 2025, the Ethics and Medical Registration Board of the National Medical Commission came out with a public notice which said that many private hospitals are commercially exploiting the patient, using them as models to fulfill their ulterior motives through live surgery broadcasts and conferences. And so various companies are promoting themselves and making a fortune out of the miseries of the exploited patients. Advertising, sponsorship, and professional showmanship overshadow the true purpose of these broadcasts, and healthcare facilities showcase their capabilities, surgeons flaunt their skills, and companies promote their products at the expense of patient safety. So all concerned stakeholders were requested to take note of some guidelines which were brought in by the NMC. So what is the core mandate? The core mandate is to ensure that live surgeries are for a bona fide educational purpose only and not for any commercial promotion or a personal glorification. Patient welfare and safety are paramount above all other consideration. There is a strict ban on using surgeries to promote individual surgeons, hospitals, or brands, that is medical devices, products, etc. Operating surgeons must not have any financial or commercial interest in the equipment or devices used. Patient identity and confidentiality must be strictly protected at all times. So what was the eligibility? The surgeon should be a registered medical practitioner or a foreign medical practitioner, requiring at least 5 years of post-specialty experience. In addition, foreign medical practitioners require a temporary permit from the National Medical Council's Ethics and Medical Registration Board, that is EMRB, which is granted by a specialty expert team. Location. The facilities should be clear. It should be an accredited hospital, well-equipped OT, both for pre-operative care, the operative care, and post-operative care. There should be a clear contingency plan, a documented plan for handling complications, with qualified standby staff and readily available equipment. Consent. There should be a clear explanation of the purpose of the live broadcast being educational. Risks and benefits should be very clearly explained, and potential outcomes also explained. There should be anonymity, confidentiality should be assured, and the patient should be given the right to withdraw at any time with no penalty, with no problems in continued medical care, in case the person says no to the surgery. Coming to the patient selection criteria, this has also been very clearly explained in the guidelines. No high-risk procedures should be carried out. No patient should be taken up without all the investigations, and not to take up patients who have an unusual anatomy. Inclusion obviously means that the patient should be medically fit, pre-anesthesia checkup should be okay for her, and there should be no contraindication for the surgery. Coming to the very important part, the financial and welfare provision. There should be no financial incentive. Patient cannot be paid or receive financial incentives for participation. Surgery should be at no cost, which includes implants, medications, disposables. Insurance and information. The insurance coverage is a must to safeguard against any unforeseen incident. Patients should be informed about the policies, availability, and limitations. Recently, we had, as early as September, CELSI conference, International Conference of CELSI, which took place in Bharat Mandapam, and I had spoke to the conveners, and they said they had specially gone through all these guidelines and made sure, in fact, because of the short duration of time, they hadn't called any of the foreign medical practitioners to do the surgeries. In addition, it was an in-house program, and they went by all the guidelines that were given by the NMC. Finally, the conduct of the broadcast. This is very, very important. Previously, there used to be an interaction between the operating surgeon and the surgeons who were watching the broadcast. But now it is very clear that the focus should be on the patient entirely. The operating doctor must focus entirely on the patient. There should be no interaction. They are explicitly prohibited from interacting with the audience to maintain patient safety. In only very special cases, a stepwise live commentary by the operating surgeon may be permitted, but without any two-way communication. In many of the cases, like in this last conference that I came to know about, there is a moderator. Usually the moderator is another surgeon who is very well versed in the operating surgeon's technique. So that moderator is designated and is responsible for providing the commentary separate from the live feed. And he can, of course, take questions from the audience and give answers because he is part of the surgeon's team. So this is a designated commentary. Recorded versus live. The preferred method by NMC is that you go in for recorded videos, cadaveric dissections and simulation-based training over live broadcast to minimize patient risk. Live demonstrations are to be reserved for only vetted new procedures, while recordings should be used for all established procedures or the high-risk cases. Oversight and accountability. Every such conference should have an apex committee and oversight committee to ensure ethical and safety compliance. Their own association should have a self-regulation, professional associations to prevent commercial exploitation, and there should be a complete record keeping, an unedited recording which is preserved for a minimum of 2 years. Mandatory permissions. These are very, very important. That prior approval is compulsory. For a government hospital, this is the dean. For a private hospital, it is the state medical council. Sponsors must also have the prior permission from a state medical council before inviting the foreign medical practitioners. This is very important. So now the shift in focus as per the new guidelines is patient first. Safety and welfare is prioritized. High quality and genuine educational value. There should be no exploitation to avoid all commercial gain. There should be explicit and written and informed consent. Regulatory compliance is very important, must adhere strictly to the guidelines. So the shift is from a glorification of the surgeon to genuine education and skill transfer, from commercial gain to ethical practice and patient centered care, from the risk of a live broadcast to controlled safety. So in short, we have to now go in by the NMC guidelines as and when we want to do a live broadcast. So the tagline is education, yes. Exploitation, no. Thank you.